Okay, so I'll start off that we have some very intelligent parents who some may speak your lingo. Like I said, I'm still learning. Fortunately, we have 2 days of this, so hopefully we can get through all the questions. We're going to start with just about NALCN and what it does. So we know that there is a wide spectrum of symptom severity between affected individuals. And so the first question is, does the location of this misspelling on the gene cause this severity, or is it the type of mutations such as missense, nonsense, deletion, etc.?
That is something we are looking at in the phenotyping study. So we know the type of mutations are different between CLIFA. They are most missense mutations, so single nucleotide changes within the gene. And in the IHPRF syndromes that are associated with the loss of function, mutations are more, let's say, bigger, like deletions or duplications, or the protein is not a full protein, so it does not work well. And as for the if the location of the mutation has some effect, functional effect, or can explain the severity of the phenotype, that is something that we are working on right now. As far as we have seen, the genetic variants that we found in the CLIFA patients affect different locations within the gene, like the linkers between the domains, the pore or the area that forms the pore, or the voltage sensor region. So, and we still don't know if the exact location has some or can explain that the severity of maybe if patients have epilepsy or not, if they are nonverbal or not, or for example the ataxia, or if ataxia happens earlier or later. This is an ongoing work on our part.
Thank you.
Concerning Clifford syndrome, that Paloma said, the localization of the mutation is very important and seems to be very important. You have some patient with ataxia, some patient without ataxia, some patient with contractures, arthrogryposis, and it seems to be different among the localization of the variation and the potential of gain of function of the variation. So with the collaboration with the team of Arnaud and Philippe in Montpellier, we have made some work to know the potential of gain function of different variation, because it seems to have a great importance on the phenotype. But Paloma said everything. It's difficult to make perfect correlation between the genotype and the phenotype of patients.
Thank you.
Yes.
If you're able to group the variations and you see that you have similar variation where you have the symptoms, do you need further search and investigation, or let's say deep dive about other informations helping to make a next step? Is this something you need? And if yes, what is the approach here? So, for example, you have seven people, several patients, which is a similar characteristic, And I think that a next step is needed for further question information.
Well, from the clinician's perspective, with other diseases, we have seen some correlation between the location of the mutation and the phenotype and the severity. And probably the same thing is going to happen with NALCN, although there would be some correlation. Maybe this is not going to be black and white. What are the other things that you mentioned that could be interfering with this tight correlation? One is, well, if there is perinatal asphyxia, you're losing some neurons. And this is a population that frequently have pre-birth and during birth abnormal problems. So, and that's going to be a factor of variation between them. Then you have the genetic background. What are the other genes? How do they interplay with NALCN channelopathy? Maybe there are some variants in potassium gene or calcium gene that are not pathogenic by themselves, but within this particular patient will worsen the disease. So I think that in this population, it's good to have whole genome analysis. We are talking in epilepsy now about the genetic score, whether different genes, none of them by itself will cause seizures, but the combination of them might. So there are several other things that might interplay, and we need to know what is the function of the mutation, how does it affect the function, and how is it correlating with the phenotype. But we also, as you mentioned, we have to look at other options that very often are very difficult to identify. I don't know if you agree with that, even though there is some correlation, but
I'm asking because we got a feedback that our son is joining this search, and it was feedback was that 7 others has a similar variation. And for me, the next question is, okay, now with this information, do we need to support, how we can support in order to find more out, understand what you're saying? There are a lot of influences and it's not black and white. And this is, let's say, an empirical approach. And question is how we can support this.
Okay, I think related to that, so families with children with UNC79 or 80 mutations, their children will be very different. Does your answer change at all when you consider how, so for example, one family, their daughter is able to speak while their son is nonverbal. Can you explain a little bit why that might happen?
I think that goes back to what Antonio was saying. Yeah, I think it goes back to what Antonio was saying. I think this is a very common pattern in genetic disorders. We just speak about inter and intrafamilial variability. I mean, it is almost the rule in genetics that we do see within families variability for these recessive disease traits. You know, as far as why does it turn out like that? It's probably a combination of we're talking about here monogenic traits, but there's also the polygenic milieu, the background that's modifying the phenotype. Not to mention in traumatic birth, other things that, you know, environmental things that can shape the course of it. So I think that's when you have 2 siblings, same genotype, different manifestations. That's what we're dealing with. But I do think, I mean, I know I'll talk about tomorrow about 10 patients with these disorders, and so it's not a whole lot. But it does seem like there are genotype phenotype correlations here. I think like we have a few recurrent variants, and it seems like the phenotypes are similar amongst the patients with recurrent variants. So I think I'm looking forward to Nawal's talk tomorrow. I think one thing I would encourage us to think about is how can we take all the phenotypic data and genotype data that we have and try to do a really robust genotype phenotype analysis. One thing that we do we've been doing more and more is breaking down the phenotype in a more quantitative fashion through human phenotype ontology, a standardized way of describing phenotypic abnormalities, and then doing a computational analysis, clustering analysis to pull out phenotypic clusters and then look and see where the particular variants are falling. I think we have a decent number of patients, 40, whatever, that's probably enough to see something, at least for CLIFAT. I think for the recessive disease, because it's essentially all loss of function variants, I suspect, I mean, we could try it, but I don't think that's going to be too meaningful.
Okay, I think now I'm going to switch into some symptom questions.
Sorry, can I ask
yes.
a question? Yeah, just relating to that, I can share a little bit of a perspective from me as a scientist 10 years ago when I first started to collaborate with the clinician. That was the first and the only time I really collaborated. That was the very first case of CLIFAT R1181Q. The reason I started to collaborate with them was because they did a very thorough genotyping. It's a whole exon sequencing of the one patient, but selected against the parents as well as a sibling who does not have the syndrome. And they come up with 2 mutations only. And then one of them is this, and then they know our work that to show there is mutations generates gain of function. We generate the CRISPR, and it was very clear. And then what's really puzzling at that time was another patient I talked to you last night in Seattle, was reported to have exactly the same mutation, and then they claim it's a loss of function. Well, I don't know what it was claimed, but there were some similar phenotype, but then they don't have ataxia. Well, our patient had ataxia. I think that was really the only time, because later on, even though there were a lot of clinicians come up to us and ask us to do so-called genotyping, ask us to verify their mutation. It's not even about verifying, just say, I found this, and then can you do that in the worm and tell us? And when I asked for the way that they've done genotyping, it was never like the way that our first collaborator has done. So for me, I think now apparently there were 10 patients reported have the same R1181Q mutation. If they have different phenotype, I think it's about time to really go back and see if it's worthwhile to do whole genome exonal sequencing comparison and really figure out. Now you have enough basis to really correlate specific background versus the individuality. Yes.
So there's a question in the chat box about ataxia and then also regular MRIs, and I'm going to draw on 2 questions that came in previously. So can you speak about the progression of ataxia? Is it all kinds of ataxia that parents should be aware of? And then combining it with the MRI question, is there a recommendation for regular MRIs? And I'm going to add, is there any association with brain atrophy? Sorry.
To mention something else, sorry, you were gonna say something. The brain MRI very often requires anesthesia, so we have to be careful by doing too much tests that are not necessary when they are so invasive. But I think any physician will take an MRI when there is a change, and if the patient collaborates, that after the age of 10, many children collaborate for an MRI without anesthesia. That would be good to have a follow-up with brain MRI. So I don't know if you.
Yeah, I agree completely with that. I think that, I mean, you say if they'll collaborate, and I suspect in many cases they will not collaborate. So I would not recommend regular MRIs. I would only recommend doing an MRI if there's a clinical indication of change in ability to walk or what have you. I will say we have one patient who had repeat MRIs and clearly went from having a normal cerebellum to having significant cerebellar reduction in volume, so cerebellar atrophy. But once you've shown that, I mean, really, after that, I'm not sure that there's too much utility in repeating it, even if the ataxia gets worse over time. We know that that process is ongoing. What is that really adding clinically? I don't think anyone has seen, I don't know, global brain atrophy. The patients that we have seen have not had evidence of that on MRIs.
Related to ataxia as well, can you speak about verapamil? And then, I know that it's been addressed earlier, but there's some parents that are interested in that.
About verapamil, we know about 2 cases on verapamil. They report an improvement on the gait. Not for episodic, the episodic ataxia, but for the overall gait and movement. So I think it is a candidate, for this drug repurposing we were talking about earlier. But we need more patients. Yeah.
Thank you. So I'm gonna jump around to symptoms for a little bit because there are a lot of questions about symptoms. But most commonly, parents brought up difficulties with speech and a variety from being nonverbal but appearing to understand, to being able to communicate in other ways, to not being able to communicate at all. Can you talk about any evidence for therapies that improve speech, or what is going on in the field right now, and what can we look forward to? Hopefully.
Well, I mean, I think, first off, that pattern of better receptive than expressive language, that's a very common pattern in neurodevelopmental disorders. And so it, is not remarkable for Cliff Hat or recessive disease for that to be the case. All children with these conditions should be in speech therapy. They should be in speech therapy from very early on. You have to be very, very aggressive with that to maximize developmental potential. And I don't really think, I don't think there are any, I don't have any other great recommendations. I'll talk tomorrow about one patient where we tried a different medicine, and there may have been some benefit, but that was more specifically with slurring of speech, dysarthria. The family, we think there was some improvement there, but I don't think there's any other specific therapy or recommendations.
Yeah, I totally agree. I think the speech problem we see in these children is not related to the cerebellum. It's not like a scandid speech that is related to a cerebellopathy, but is more related to a global developmental problem. And this is something that what we do is emphasize speech therapy.
Thank you. So in addition to the ability to speak, there were many parents hoping to find out if their child will eventually be able to walk or meet other major functional outcomes. There's also, we know, children who walk early on and then no longer are able to walk. Are there any signs that predict future development and prognosis? And is there an age or another point when you would expect development to have reached its peak and stopped? When do you not expect further development or milestones?
I don't think we have a clear answer for that question. As Antonio mentioned earlier, we don't know about very old patients. In our series, the oldest patient was 27 years, and half of the patients were able to walk. They developed walking at about 3-4 years old, and if many families, most of the cases, did not observe any regression in developmental milestones. I think that does not happen in CLIFFAD or IHPRF, at least for the cases we have in the study. Maybe in the CLIFFAD patients, you can observe a worsening in the gait because of the ataxia. ataxia can develop maybe from, I think, from 7 or 8 years old. And it can make the patients need more assistance or on walking. But I don't know, I don't think we can say that, say an age or a moment when this happens, or we don't know many things about long-term prognosis. So.
In the literature concerning Clifford syndrome and walking, we have several phenotypes. There is some example, an adult of 38 years old, and he can able to walk in 4 years old, and walking becomes to regress, have 30 years old, something like that, yes. But you have several other people, they have an age of working capabilities later of other people, and the capacity of increased working are better, but they increase progressively. The regression is maybe possible, but after several years, but it's not very good defined. So the prediction of walking is hard, because you have to have the whole history of the patient. And as Paloma said, you have several pictures of walking and evolution of walking. I follow a girl of 13 years old in France, in Dijon, and she became to walk at 3 years old, and she increased her capacities, her walking capacities, at 8 years old. When she become to she was in the apprentissage of the work, she has a lot of ataxia and episodic ataxia, and with the advance in the age, the ataxia decrease. So it's different, that table of the literature and picture. So it's difficult to predict for each children.
Thank you. I know a lot of parents would, oh, yes, go ahead.
Was there a special treatment done for her that she decreased the ataxia? Because for me, I really appreciate Paloma's and Antonio's survey and search. What I'm looking for is, and I'm learning that everybody or a lot of people are doing such search and studies, how it will be somehow consolidated that everybody can have further results out of these overall studies in different regions, in different countries. And this is going to this question as well, because this is a very important question, I think, for everybody. Ataxia, we learned about treatment proposals, understood that this is not the solution for everybody. Every patient is different, but I think this is going exactly in this direction.
Yes, concerning this girl, her mother was against drugs treatment, so she takes some vitaminotherapi like selenium, vitamin A, C. I don't know if this vitaminotherapi or her natural progression, but the progression is here, and she has several physiotherapy and rehabilitation program each year. Maybe it's an element of answer too. In Dijon, in our center, we test with this girl 2 treatments, acetazolamide, but it doesn't work with this girl. And another treatment, because I have talked with a team in Canada. They write a paper. The name of the physician is Ayogi, and I talked with the pediatrician, Dr. Elsa Rossignol, and she had make a test with this boy of the article because he have an excessive drooling. It's a symptom. You can meet in the Clifford syndrome, and one of treatment in excessive drooling is anticholinergic treatments like scopolamine or atropine, the type of treatment like that. And she observed that the excessive drooling decrease and motor effects. So we have made a test in the girl from France. She had performed concerning motor function. Before this treatment, she can't run. After 4 days of this treatment, she can walk better and run. But rapidly, she developed adverse effects like insomnia or hyperactivity, and it was not possible for the parents. So we stopped the treatment. So we have some maybe targets of treatment, but it's in an experimental state.
A question on excessive drooling was also in here, so thank you. So another question is, can you please talk about staring spells and NALCN related diseases? A couple parents noted their children staring off or not blinking, even when trying to get their attention. Are these always related to seizures, or can they be unrelated?
Well, this is a question that is frequently asked by parents of children in general. Then when they stare, is this a seizure or not? So there are some hints whether the child, this staring happens and is immediately over with no deficit. And when the parents wave the hand and the child reacts, or say something and the child reacts, then most likely it's not a seizure. But if they do not react, or the staring is very obvious and there is associated with a change in facial expression, and if afterwards he is a little bit sleepy or dozing off, and if it happens usually in the morning when the kid is not completely awake, then you tend more towards seizures. At the end, the best way to get out of the question is to perform an EEG and try to capture some of the events. And if that's not possible, take a video and show it to the neurologist, and he will probably be able to improve the diagnosis.
Thank you. Yeah.
Just and on the note of videos, we've been talking a little bit about some abnormal movements in CLIFAD and whatnot, and I think in general, if videos are so helpful, so many things, dystonias, dyskinesias can be diagnosed just with a good quality video. So have your phone ready, take a video. You know, there are a lot of people here that would be happy to review them and help out answer these questions.
Just a quick time check. How long are we going? Okay. Thank you for that. So let's see. So can you share what's known about vision? Okay, so there's a lot of questions that I think are now going to be answered by the phenotype study, so I might skip around. So parents, hopefully we can get your slides. Is that possible from earlier, or sure, is it better to repeat the questions? Okay, we'll go through some questions. Oh, Patty, you want to ask your question?
Oh, yeah, I have a question, but it's unrelated. So if you want to continue on, I can ask after you're
Go ahead.
done. Unless you want me to ask now.
Yes, please.
Okay. I just had a question on the like the schizophrenia piece and like the neurological pain. would that be from like onset, or is that something that a child can develop as they get older? And like, how would it be diagnosed?
I'm gonna provide what I usually tell patients when they come with diagnoses that are usually performed in patients who are otherwise neurologically healthy, such as attention deficit, schizophrenia, psychosis, depression. When you have someone who has schizophrenia and nothing else, this is a garden variety schizophrenia with usually good response to neuroleptics. With attention deficit disorder, you have the same thing. If it's attention deficit and nothing else, and the rest of the examination is normal and there is no other neurological problem, they usually respond well to proper medication. But when you see someone, a patient, a person who has a neurological problem and schizophrenia is a symptom, or attention deficit is a symptom, then we should think about this in a different way. It's not like we're going to treat it like any other schizophrenia. That doesn't mean that we are not going to try medication for schizophrenia, but it's not the typical schizophrenia, and the response to treatment might be different, and maybe the term schizophrenia is not exactly properly applied. So I would say that for patients with NALCN disorders, we have to think about the symptom and try to help with the symptom, but we might have to move away of labels, of common labels, even though they may help to choose the drug you're going to try first, but you still have to be creative and try to find other explanations. That's in general for developmental encephalopathies. I don't know.
I agree completely. I would be very reluctant to diagnose schizophrenia in the patients that we've all seen and discussed. I think that's something that requires you need someone who's a really fantastic psychiatrist with fantastic background in developmental disabilities to diagnose schizophrenia in a child with significant developmental delay.
So related to that, there were some questions around managing mood, anger, other behavioral challenges. Are there any recommendations, either interventions or therapies for other types of behavioral or psychiatric challenges?
So about behavior problems, so and there is a long list of medications that the patients in our dephenotyping study have tried. I don't think there is one drug that is clearly better than the others. Maybe I mentioned gabapentin may have an effect because patients taking gabapentin reported an improvement, and I didn't see any worsening with the gabapentin, but I think the behavior problems can be very difficult to treat in these patients. They have a lot of attention deficit disorders, and maybe it is also related to the sleep problems, that they don't get to sleep all the night. So and it's very challenging, I think. Mm-hmm.
Speaking of sleep, is there anything you can recommend for improving sleep? Any medication from the study?
We are in the same point as with behavior. Many patients tried melatonin. It can be effective or not. Maybe gabapentin can be also effective for sleep. And we haven't seen any other drug like for example mirtazapine or trazodone or benzodiazepines. This drug that doesn't seem to have an effect on sleep, so it's also very challenging to treat.
Thank you.
Sorry, question for all of you. Are you happy with using benzodiazepines early in sleep problems in these children that you know that the sleep problem is gonna be over and over? How would you use benzodiazepines early or?
That's a good question. I, to be honest, I mean, again, talking about common themes and developmental disorders, autism, and sleep problems are almost the rule rather than the exception, and can be the most challenging part of these conditions. And I mean, my personal experience is just, it's very trial and error, just like what you all are describing. And I tend to go with the try to avoid medicating to fix sleep problems, because in general, I think it leads to more problems than it helps with. A lot of times, behavioral interventions, exercise, other things are better than pharmacological treatments.
Just concerning sleep disorder, it's important to diagnose this and to think about differential diagnostic as epilepsy, central apnea, and trouble like respiratory infection or upper infection, because the girl that I follow, she had very episodes of upper infection, respiratory, and it was maybe a problem for her sleep disorders. And after treated these episodes, her sleep was better. And it's important to make other diagnostic and to not treat just sleep disorders. Maybe it's important to see for all the family to know that.
Using AlphaFold, looking for, you know, chemical binding partners and stuff. So that's what the AI that I've been curious about, right? People are using this technology to identify 3D structures. Who knows if it's right, but now we have lots of information on the actual structure. But are people using sort of chemical? I think that's what maybe the question could be. For folks who are doing structure function.
I have a question, but actually it's I want to formulate a question Patricia brought. If I understood correctly, she mentioned a pain, neurologic pain or neuropathic pain. It's something we haven't talked about yet. So I'm curious. We know from animal models that NALCN is a pain candidate somehow at different levels. So I'm curious regarding patients, clinicians, whether pain is considered, and if you are aware of excessive pain or reduced pain somehow.
In the phenotyping study, we observed a reduced pain sensitivity. patients, especially in Clifford syndrome. I knew of patients that had some big injuries, and they did not cry or anything, just like they didn't feel the pain. And that I'm also curious as to why this is happening. I don't know if you have observed.
Just a quick notice about what was published regarding, for example, excessive NALCN activity. There is a story that describes that in some neurons, there was a higher expression of NALCN, and it was efficient to actually make this animal model being insensitive to some pain. So it's something that has some basic support somehow.
Concerning this question, I asked to myself, maybe there is an action in serotonin neuron, because neuropathic pain and spasticity are linked with. And we know in animal studies in spasticity that the first step of spasticity is serotonin neuron. So maybe there is a link between these two symptoms. And in a patient with Clifford syndrome, in the literature, spasticity is never precise in the case, but for example, in the girl from France, follow-up in Dijon, she has a little spasticity in triceps muscle, and I ask, maybe there is a relation between hyperalgia, spasticity, and neuropathic pain in some cases.
We were just talking earlier about this. So I see patients who have congenital insensitivity to pain. This is a form of hereditary sensory and autonomic neuropathy. These are other genetic disorders. I'm not talking about NALCN. When you have a severe absence of pain sensation, you will typically develop recurrent ulcerations of the hands, the feet, often leading to autoamputations, osteomyelitis, bone infections. This is not what we see in these disorders. The insensitivity to pain, I think, is the more non-specific insensitivity to pain that we see in autism, in intellectual disability. I don't think it's rising above that level.
I'm going to say.
But thank you for this panel. There are several, I would say perhaps more than 10 of some of the variations that have been functionally characterized, and that's fairly quantitative. Some of okay, if we only measure, this gives way more work in a function or not. If it's my reading that they don't seem to correlate with the severity of the symptoms. Is that correct? If not, you have to wonder, do we have to go back to say those characterizations are not really that so useful? Maybe we have to think about something else. Do you have enough data to analyze them? So this one is more severe based on.
I don't think we do. I'd leave it open to the rest of the panel, but again, I'm obviously not involved in directly generating that data. But what I can say is that in other channelopathies, we're finding very often that there are other properties that the variants are inducing that are contributing to these genotype-phenotype correlations, activation of the unfolded protein response, variations on that, other electrophysiological properties other than just what we've been discussing today. So
I'm going to save some questions tomorrow and move on to an area that I think a lot of family research here. Thank you. So there's a question in the chat box about ASO therapy and how far off it is. But maybe in general, if you can just speak to gene therapies and yeah, maybe summarize what's been discussed today. Maybe I'll be more specific, like what is the potential in the new future? And then I think there was also some questions from parents about collaboration with gene therapy centers in the US. Yeah.
Okay, so gene therapy, you can think of it, there's two possibilities. There's correcting the variants in your DNA, which is the vision for CRISPR and variations on that. And then that is very far off for neurological diseases for a lot of reasons. The more immediate possibility is the viral delivery of the normal copy of the gene, as has been done in spinal muscular atrophy and several other disorders by now. That would be a great option for recessive disease, right? Because you don't have NALCN and you can give it to people. And we know that there are the UT Southwestern group and many others who are have been very successful at preclinical and increasingly clinical trials of doing just that, targeting the nervous system, the central nervous system. For CLIFAD, because it's gain of function, you're probably not going to get away with just giving them more of the wild type protein. And so I think the antisense oligonucleotide strategy is very interesting. I'll talk a little bit more about that tomorrow. That's going to probably have to be individualized for almost every variant, and there may be some variants where it may not even be possible to get specific targeting of that said variant. So there's a lot of challenges about bringing gene therapy to patients with these disorders.
Okay, thank you. So this came through in the questions and also now about collaboration with US researchers, children's hospitals. So maybe I'll just broaden that question to say, how can families help move research forward, particularly related to developing treatments faster, and how can we support you all?
Well, collaboration is always important. And our goal, I think, is one of the reasons you set our workshop is because you want to establish collaboration among others. It's not only sharing information, it's from this work together and finding solutions and answers and help as much as we can. So I think we're aligned with the same idea that we have to collaborate, and I think all of us here want to do it. So thanks for having the opportunity to comment that.
I think when parents receive the diagnosis, at least we did this, and I've heard from other parents who did this, they reach out to the first authors, the last authors of journal articles. Can you explain some more specific examples of how we can create collaboration between our providers and between you all in this room, and what are some actions we could take? Sorry, and then because I mentioned providers, it's for many families, their pediatrician or even their geneticist has never heard of CLIFAD or IRPF 1 and 2. So how can we help the providers?
I guess, communication. I think the best way to help with disorders is to communicate. And I know that this is difficult because physicians are always very busy in the clinic seeing patients and then in rounds, and there is little time for communication. And I think this is a big challenge for, I guess, all of us. At least I can say from my side, finding time to talk to physicians and to families and getting data and sharing data sometimes is difficult. But well, we have to make efforts and collaborate also with the treating physicians and incorporate them in the team. And you were mentioning about policies of publishing papers and who goes first, second, and third. And well, there are some rules that we tend to apply, but they are kind of flexible. And these rules are not fixed. And usually when you set collaborations, I understand that many physicians and investigators at the end of the year, they need to show that they have done research, and that's usually having articles published. When you have a group of collaborators, usually many articles are published and there's room for everyone. So I don't think that should be, that should hamper collaboration, so.
Thank you. Maybe moving more specifically into some of the current research. One parent asks, can you talk about the mouse model and what experiments are planned for it?
Yeah, and not.
Yeah, so about mouse model, okay, to my knowledge, there are two. We developed one with the support of the Libellas Foundation, actually. But this model, we call that a preclinical model, actually. So it is under characterization in the lab, so it takes time. So we have first to determine whether there are phenotypes and whether these phenotypes reflect the disease. And the next step will be to try some gene therapy also, and maybe some molecules that have the potency to rescue phenotype. So, but it takes time, unfortunately. But there is a very important word, it's collaboration.
Thank you.
I'll add on, I'm going to talk about this more tomorrow, and we've been talking about this a lot. The idea of the longitudinal studies, the natural history, that's really important for bringing any of these things to the clinic. When we go to the FDA, I mean, in the United States, the FDA to try to put in for an IND, a new drug request to do an investigational study, they expect natural history data that we can use as a benchmark to determine efficacy. This is a huge issue in the ultra rare diseases, and so the sooner we start collecting that data, and again, these guys have done a fantastic job of getting us to where we're close to that, but we need to have longitudinal data in addition to take it to the next step. So I think that collaboration and for the families collaborating with the programs that come out of this, it's going to be critical.
Thank you. So there were some questions about the phenotype study. Thank you for taking that on. So one specific question was, with NALCN playing a role in cancer metastasis, did the phenotype study identify any patients with cancer in their medical history? And if so, what was, okay.
We did not identify any patients with cancer.
Okay.
So they are very young also.
Yeah. Thank you. Another question was
just because there are another question like that with the ferritin levels and cancer. Yeah. It has to have other disease and the NALCN disorder. It's possible.
Thank you. Another specific question with regarding the phenotype study was recently there was an article that came out about a professional athlete with a de novo mutation on NALCN who seemed to be thriving and was diagnosed by chance. Did you attempt to reach out to the study authors to see if this person could participate in the phenotype study?
I didn't.
Okay. An idea from a parent. Question in the chat box about, is there anything that we can do to advance the phenotype study now? Oh, anything else to elaborate on about the athlete? No. Oh, okay.
When we started the study, we came across a family where the father also had a mutation and he was asymptomatic, except that he has some mild club foot, so almost asymptomatic. And this was a person that was having normal life and he was an athlete, but not an elite athlete. He performed very well, but he disappeared. We were not able to continue the study with this person. So if he's listening to this, please call.
Is there anything that we as families can do to continue to support the phenotype study? Are you still enrolling, or you continue to gather histories?
Yes, we are still enrolling patients, so everyone is welcome to participate. And I think well, I can send a lot of emails, and sorry for that, but maybe what we needed is more specific data in, for example, the EEGs or sleep studies. For example, about sleep studies, it would be very interesting to see if there's some kind of disturbances in REM sleep, or for example. So anything you can share with us, just you can email me or Antonio or any one of us, and we'll be happy to help. And
Thank you. There's a follow-up question about low ferritin levels. I don't know if you also want to address that, about recommending iron infusions or supplements.
About about vitamin supplements, and just if you detect some deficiency, then you may supplement it. But I don't know about any improvements just for supplementing any vitamins or iron.
It is important because iron deficiency long-term iron deficiency is associated with lower IQ and other developmental problems. So definitely speak to your pediatrician, have that thoroughly evaluated, and yes, consider supplementation or infusion if it's warranted.
There were actually quite a few questions about recommended supplements in addition to recommended medications, but so in general, just to broaden that, are there supplements that parents should be aware of? Yeah. Any best practices?
Well, supplementation is a very broad term. Supplementing vitamins with a multivitamin, I think it's okay, it's good. Sometimes we think we have all our vitamins fine, but there is someone missing. So why not getting some supplementation with vitamins? But then if we run into supplement, maybe fatty acids and other things are benign, we can take as much as we can, and that's not gonna cause any harm. But if we get in complex supplementation, that'd be worrisome. So because that could cause other health problems. So I think do supplementation, but again, talk to the pediatrician and check that this is the right supplementation.
Thank you. I realize I'm jumping around a little bit. So but I know this is an interest for several families. So we talked a lot about NALCN related diseases in childhood. So now I want to spend maybe like the last 8 minutes or so talking about the manifestation of these diseases in adulthood. Can you speak about the studies, if there are any, on the evolution of the syndromes in adulthood? Can you comment on if there's comorbidities that parents should be aware of? And as a final question related to this, do epileptic seizures continue into adulthood?
The phenotyping study, we don't have so many old patients. It's a difficult question because we don't know the prognosis in long term. If seizures have been refractory to treatment, then they will likely continue to be refractory. And as for any comorbidities, I would say maybe as we talk about any iron deficiencies or vitamin deficiencies, or but I don't know of any specific comorbidities associated with these syndromes.
Just to comment on the adult thing. So, and to give a little perspective, at least in the United States right now, everyone that's being diagnosed with one of these disorders is being diagnosed either through some type of a gene panel based testing or through exome sequencing or maybe genome sequencing. In the United States, it's very hard to get this done in adults. Most insurance plans will not cover this for intellectual disability or other possible indications for testing. So that's a major reason why we're mostly finding children with these conditions. So I wanted both to give you background on like why, you know, why we don't have a lot of information, and also to maybe hopefully make you feel a little bit better about the fact, like, what does it mean long term? You know, earlier we discussed it that there is some mortality associated with this condition, but you know, it's very likely that I think that there are lots of adults out there with this condition, and just simply they're not undergoing molecular testing. In contrast, and Antonio, I think, mentioned this earlier, disorders like Dravet syndrome from SCN1A, that is a clinically recognizable syndrome, very distinct, that has been recognized for decades, and the gene's been known for a long time. And we've been doing single gene testing for quite a long time. So there's reasons why certain conditions we have lots of older patients and lots of longitudinal data, and for this one we don't yet.
We are on time. For the remaining questions, there is another slot tomorrow at 4. Okay, so I would like to thank families to be here, either in person or in video. Thank you so much. Thank you, Nawal. Thank you, Paloma. Thank you, Antonio. Thank you, Daniel. It was very instructive. I hope that families appreciated your answers. So thank you, and see you tomorrow.
Thank you.